You know, it's so funny. When I discuss this with the women in my life, uh, they eh, they rarely disagree, with the statement that men can be doofuses. We tend to neglect our health, and um, the classic people think, well, men's health is prostatitis, erectile dysfunction, prostate cancer, etc. But when you look at the major causes of death, like the top 10 causes of death, men get a lot more of it a lot faster, 8 out of 10 of those, than women. So, and then they turn around and ignore it. I say they. As you have noticed, I am a man, and I tend to do the same thing. I focus very well on things that, the big things, but I still, sometimes the cobbler's children have no shoes. So we'll talk a little bit more about men's health today. Um, Another reason that we're getting into that is that because of the Medicare practice, we've been doing mostly specialty prevention, but as you get into Medicare, you end up doing a lot more primary care. So we're getting back into that. What brought this up was, speaking of men neglecting their health. I have a patient I have a lot of patients who are doctors. Um, the largest doctorate level healthcare group that I have as patients is dentists. I just have a huge number of dentists. But this was an ER doc, and he was complaining to me about a month or two ago about erectile dysfunction. We gave him we used some Cialis, and he came back and he said, well, dang, yeah, it helped a little bit in terms of erectile dysfunction, but I tell you, even if it didn't, I'd still want to use that. And I said, what happened? He said, I've gone back and read up on it, and I had prostatitis, chronic prostatitis, and never really thought about it. And I'm getting major relief. So, we're not at all starting up a urological practice, but, some of the basics, we need to step back and just think about them. So we'll be talking a little bit more about that today. If you're new to this channel, we usually focus on prevention and the things that are more likely to kill and disable people in the world. We used to say, 30 years ago, you said in the developed world. That was the term that was used in public health circles. Heart attack, stroke, diabetes were first world diseases. You didn't see them so much in the BRIC countries, BRIC, Brazil, India, China. But now that food access has become so much less of an issue in those areas, this has become an issue there, the biggest issue there as well. So it's the whole world dying and becoming disabled from, yes, heart attack, stroke, dementia. But once you start boiling down the core risk factor, there are core risk factors that drive the vast majority, as in 80 to 90% of all of those. And it's diabetes or prediabetes or, quote, a touch of sugar, end quote, which at the end of the day are all the same disease. So the kind of things that you've seen on here, we'll focus mostly on that. We'll also focus a little bit on how you can get this. One of our big challenges has been that we're expensive. We've been patient direct pay for from the beginning for about 5-6 years as we've gotten started up. I've had more and more experience in the Medicare fee-for-value world, and most recently in a big Alabama project. We're taking what we've learned there and making this accessible through Medicare to Medicare enrollees. And in fact, again, that's one of the things that Jesus will be providing today. One of the things we covered recently was, can you really get prevention on Medicare? The bottom line is, yes, you can, It takes a little bit longer, and it takes a couple of more visits than you would in a standard environment like we've done before. But here's the thing, that's one of the major advantages to telemedicine. Uh, if you do direct pay, you pay a lot more, but we can go ahead and get cardiovascular inflammation panel. We can get fractionations. We can get OGTT with insulin response. You can't get those coming out of the blocks with Medicare, but you can get what you need. You just have to do multiple calls to get that set up. So I don't know if we're going to get to any of that today. I think Jesus is going to be a little bit more, give a little bit more basic nuts and bolts in terms of what's going on with the processes. If you, again, this is for folks that haven't been on our channel before. There's some key things that that we have focused on. Core curriculum. It's clear. This is not just some internet doctor saying that other doctors don't do the right thing. This is, I mean, my old cohort at Hopkins started it, then Mayo Clinic picked it up, Harvard picked it up. There's a major disconnect in what's available in terms of medicine and what's needed in terms of medicine. The bottom line is this thing that's disabling and killing most people, the major risk factor, prediabetes, diabetes, is something that 2/3 of primary care docs in one of the most advanced healthcare systems in the world, the US, 2/3 docs don't know how to diagnose prediabetes, insulin resistance, metabolic syndrome. And if they can't diagnose it, how well do you think they're managing it? Not very well. So our core curriculum sets it up where you, as the patient, the person, it's your health, it's not your doctor's health. You need to learn a little bit. And sure enough, within just a couple of hours, you can learn a lot more. You can learn more than your typical doc knows about insulin resistance, about plaque evaluation, about cardiovascular inflammation, things they just don't get yet. They will, but it'll probably be about 30 more years before they do. So let me, again, if you're there's several different ways to access our content. YouTube, if you'd like to help us get this content out to the world, we get a lot of kudos for saving lives, and we are regularly saving lives. Join our YouTube channel. That helps that helps us get that information out there and lets you be a part of it. If you're more of a locals or Rumble person, we have that as well. I'm going to skip over those comments, and as we get to the Medicare stuff, I'm going to hand it over to you, Jesus.
Absolutely. So let me walk you through a little bit about what the PrevMed Care Management Program is about. So just as Dr. Brewer mentioned, there are some extra steps that Medicare requires for a practice to get started on this type of service. And patients sometimes have to just bear with us a little bit on this process. It's different to a cash paid and direct pay service. So for somebody who's interested, and that we are, many of you may know that we are running a pilot program for a couple of months now, and we are on the next steps with those folks, and we are starting to accept a couple of patients outside Florida, but we are not opening it up completely yet. And what I can tell you about the process right now is that if you are looking to get this type of care with us, this is what you should be expecting. So if you filled out the go ahead, Doc.
Let me interrupt just a second and give you a hard time. So before we had some conversation before we started the show, and obviously we talked a little bit about Jesus's pajamas, but we also talked about what he's going to be trying to cover today. And he was saying, well, we're starting to open up, but I don't want to open it up too wide. So here's what happened. We just put out one email to our email list, and we were asking, okay, so if we do Medicare, are you interested? The response was, we had 200 people respond and say, yes, I'm very interested. I'd sign up. And by the way, I'd bring an average of 2 people with me. So 600 people saying just from one email. And, these emails, you get what, 10 to 30% of people opening those up. So we shut down the emails because, we want to manage our processes and access appropriately. So we've had a lot of discussion on how to do that without, you know, uh, making folks, coming in too quickly, having a glitch in terms of processes and things like that. One of the things that we have, for example, what Jesus is talking about here, the CCM program, we've had to work through a lot of challenges and glitches. And again, Jesus has done a great job of it, but that's not something that you just, okay, we're gonna implement that and then we're off to the races. Also, I think Michelle would probably hit him in the head if he opened everything up completely. Where she is still in the midst of piloting the very bureaucratic billing process that Medicare has. So uh, back to you, Jesus.
Yeah, and you're absolutely right. And there's a waiting list, so that's basically what it is. And we will like to be able to get everybody on board as soon as possible, but we want to make sure that we're not making any mistakes and that everybody is getting the high quality care that they deserve. So that's why. And just a quick walkthrough of what you should be expecting. So either you already sent an email on that survey, or you called us, or we already got your email, right? So we will send you an email inviting you to the process. We will ask for some general information about your insurance. We have an eligibility team that we will check that out and will get back to us to see if you're eligible. If you are, we're going to get back to you and ask you for more information. And this is more related to your health status, a health history form, and another couple of questions that Medicare requires. And if you are eligible to get an AWB, if you don't know what an AWB is, it stands for annual wellness visit. And Dr. Brewer covered this last week on the YouTube live. And this is not a physical exam. This is just a basic evaluation that you can do every year, and that help us to identify any health risk factors that you have. So we want to have you doing that with us if you are eligible for that. But that it is not a straightforward visit. Since there's so much information to cover in an AWB, we're going to schedule you first with a nurse, Nurse James, and we're going to gather more information from you, run a couple of cognitive tests, depression scale tests, and identify some risk factors. So we get you ready to see Dr. Brewer in a more efficient manner. Um, After seeing the nurse, you will see Dr. Brewer, run the AWB, and then we will have you set up to have a specific visit with Dr. Brewer, which we call evaluation and management visit, to address those factors, cardiovascular health factors that you are worried about. If you are not eligible for an AWB, that's fine. We will set you up directly to see Dr. Brewer. And after that visit with Dr. Brewer, we will set you up to get some labs, schedule you again to see Dr. Brewer in maybe 3 months to 6 months, depending on how you are. But we're also going to enroll you on the chronic care management program. And this is something that we are looking for to get involved all of our pilot patients and future patients on Medicare, because it's not only the visits from time to time. What it helps a lot is you getting involved, answering the surveys that take about 45 seconds to answer, keeping us updated on your progress on weight, blood pressure, blood glucose, etc. And we will also set you up for another visit with Nurse James to discuss your medications, check up on your progress, etc., between visits with Dr. Brewer as well. So that's basically the follow-up. That's what creates impact. This is a program that is done to keep a close follow-up with you. And this is the difference between preventive medicine and fee-for-service.
It clearly is. So, it's interesting. Back, oh gosh, 10, 20 years ago, when I was medical director, I've been medical director or chief medical officer for a lot of national companies. I remember when I was chief medical director of a company called Premise. It's named Premise because it's premise on site. It's providing healthcare. primary and preventive care to large employers, the Fortune 500. And the CEO, Stewart, and I often had conversations about how so much advantage would happen if we could get folks used to the idea of telemedicine. Now, why is that? Again, it all boils down to something that this population, this subscriber group knows very well. If you've heard it once from me, you've heard it 1,000 times. I'm a scratch record. Your health is determined not so much by your doctor and what your doctor prescribes or um, things like or procedures. Your health is determined by decisions and activities you make all day, every day. What you eat, how much of it you eat, your exercise, stress management, your health behaviors. Well, if that's the case, then setting up a medical system where you really pay the doc to walk in and slap you on the back and say, "How's Uncle Johnny?" write you a script and get out to go write somebody else's script really does not impact your health. Now, be careful what you ask for. We couldn't get back in those days, 10, 20 years ago, we couldn't get people interested in telemedicine. Well, a thing called a pandemic happened and everybody went to telemedicine. Meanwhile, Medicare has been struggling, trying to get primary care docs more into prevention, out of this fee-for-service, write a script and run to the next patient, and more into helping the patients understand how to take responsibility for their health. Well, when you begin to look at the core components of what Medicare is doing, Medicare is slowly but surely and very bureaucratically transitioning into more of a preventive type of program. The two things that Jesus mentioned on this slide, AWV, like he said, it's not a hands-on physical. In fact, Medicare doesn't pay for an annual physical. You may not know that. You may think that's happening. No, it doesn't. CCM, same thing. It's not a physical exam. It's helping the patient interact with the doctor's medical team, the patient's medical team, to understand what their best health behaviors are, making sure that patient knows what they need to know, make sure you know what you need to know to manage your health to the very best that you can do it.
Yeah.
And again, that's education. Education. Go ahead.
I'm sorry, and I will add, it's awareness, right?
Yeah.
If patients are informed, sometimes with this follow-up, they will realize that there's some stuff that they're not doing that they might be able to start doing. We also provide more direct communication with you, so it's easier to reach out to you than in an email with the process and the platform that we're using. We didn't mention that. We use a platform that is called CCIQ, which makes communication a lot easier. And I wanted to specify, right now we are accepting only straight Medicare, traditional Medicare. We want to accept Medicare Advantage and other insurance. I'm confident we're going to get there down the line. And an alternative that we have for people who are not on a straight Medicare is the subscriptions. Because with the subscriptions, we are offering access to that CCIQ platform, to that close-up communication and follow-up that is not completely as on the Medicare program, but it's really close.
Very good. Good point. So what about, doctors charging patients when they're Medicare enrollees? Any comments about that?
Well, specifically for AWBs, Medicare pays for the full amount for that. On the chronic care management program, it is important to notice, and we do send a consent form to patients about that before they enroll. Medicare does have a copay of like 20% for the chronic care management services, which is basically the amount of time that we spend following up and updating your chart and communicating with you, setting your lab orders and everything, setting appointments. But if you have a secondary insurance, that is covered by that copay gets covered by your secondary insurance. If you don't, we're talking about The average is about $20 a month.
I
So
thought it was closer to 8, but it depends
uh,
on what level of care you need.
exactly
20%, right?
10 to 20. Let's put it
Yeah.
that way. Yeah, $10 to $20 a month. Yeah.
And here's one way to look at it, and it's one of the things that Jesus and I have talked about multiple times, and Michelle as well. With the CCM programs across the country, Medicare has found, gosh, this saves Medicare a whole bunch of money. Well, how does it do that? Because people actually participating in CCM are healthier, so they don't end up in the hospital. Hospitalization is going to cost rarely as little as 25,000. Most most of the time, $50,000 to $250,000 for things that are for the most part preventable. So if Medicare can get you focused on interacting, talking just 40 seconds a day to fill that out and interact and give that information on what your health behaviors are with your doc and whether or not you need some help with your doctor's team. If they can get you to spend that 40 seconds a day or even 40 seconds 3 times a week, plus $8 to $20 in terms of your own money per month, it saves you and Medicare huge amounts of money, not to mention the fact that you don't have to spend time in the hospital.
Exactly. All right. So thank you so much for having me here, Doc. I'll drop off now, and nice to be here, and we'll join you a couple of times later.
Very good. Good to talk to you, Jesus. Thanks for joining us. So we're going to be talking about men's health today. One of our more popular topics is supplements. We get a lot of questions about those. We've already had a few questions on those this morning. It just so happens that we went back and forth on that. Over the past few years, we actually even considered making our own brand of supplements. That's A, too much of a headache, and B, a little bit of a distraction from our core activity. We don't want to become one of those companies that becomes, you can't trust our advice because you don't know if we're making money off of what we say about supplements. So what we've done is we've gone with a group called Full Script. It makes things very, very simple. Yes, there is some bonus that comes back to us, some commission, but we can share with you exactly. It's not significant for what we do. But one of the key things is that we've set it up now where you can have our protocols. We get so many questions about what to take, where to get it, what brands, how much, and you'll see one of the first questions today is how much of something to take. And the easy way is just to go to our website, go to the Full Script pharmacy access program and just take a look there. And you'll see some stuff about men's health. Miranda, who works with us now, I met her at Physician Partners. She was doing a lot of quality control work with docs and for docs, and she's working with us now. And she developed a men's health supplement protocol. Many people have said, "Hey, doc," one of the other questions we got today already is there a doctor in the Atlanta area who's using the Brewer protocol? And the answer is no, not that I'm aware of just yet. But we have heard and continue to hear the multiple requests to get docs that know what we do and practice that way. What we would suggest is that you meet with your doc or that you refer your doc. We've got both a YouTube channel and a website specifically built to help your doctors. Now, why would I put that much effort into it? Well, having me, one doc, and I'll end up hiring more docs to help us in this space. But that's still a drop in the bucket compared to getting docs to develop a network. So we're very open to that. And the other thing was, frankly, it was fairly easy for me to set up because That's what I did for physician partners. My goal, I was the chief science officer, and my role was to train doctors in how to do this type of prevention and how to do it using Medicare. That was my, besides being the entrepreneur and owner in the Alabama project, that was my major operational role there. So basically, I had the educational programs already built. We just had to reskin them for our upcoming network. So if you'd like to get your doctor doing this the way we do it, it's very simple. All the information that he or she needs is right there. Really, usually what they need more than anything else is motivation. And one thing that you can tell them is this, at the end of the day, what's still most important to most docs is to do the right thing for the patient. Well, this is clearly, I don't have to tell you that, this is doing the right thing for the patient. Doctors are people too, though. They like to make money and they like to go home and spend time with their family. And actually, those things all help as well. If you look at what doctors are doing these days, physician burnout is a major, major focus. And it's because they're on that treadmill. I hate to say it, but it's true. Over half of docs, as they retire, as they burn out and retire, will sell their practice back to local hospitals. Now, local hospitals will say, oh, we do fee for value. And sure enough, if you look, they'll have a fee for value program somewhere in their hospital. But again, this is not me criticizing other people. This is me quoting the science, the data. Harvard just came out with a big look at this, surveyed where patients are going. Over half of docs selling it back to the hospital. The hospital, in turn, says they have fee-for-value preventive programs. The primary care programs owned by hospitals have an average of 10% of their compensation for their doctors based on value. The rest of it's based on quantity and a thing we call resource-based relative value units. In other words, more than anything else, how many referrals they get back up to a cardiologist to do a stent or a stress test. It's just not where it needs to be yet. Healthcare is buyer beware. So we're going to transition into some of the science for today. The first one is a science short. To reduce appetite, skip late night snacks. Really? We get a ton of people that go into what they call intermittent fasting or time-restricted eating. This was a randomized clinical trial. So, that is the best kind of research, the best kind of citation. And here's what they did. A randomized clinical trial for this kind of thing is not going to include a whole lot of subjects unless you've got a whole lot of money, which none of this is going to develop anytime soon. It was published in the journal Clinical and Translational Report in 2022. They used 16 patients. The authors determined the effects of late versus early eating on the results. And, this is not going to be a surprise to anybody, or it shouldn't. You get anybody and everybody that's in this field, like, most specifically, Walter Longo talking about this and some of the other guys involved in time-restricted eating. Late eating increases wake time hunger, decreases 24-hour serum leptin. Late eating decreases wake time energy expenditure and 24-hour core body temperature. In other words, it makes you hungry, it makes you sleepy, it makes you store fat. It alters your adipose tissue gene expression, favoring increased lipid or fat storage. Combined, these changes on late eating increase obesity risk. So bottom line, you decrease your energy and increase your obesity when you move your time-restricted eating to the evening. Now, what do most people do? Time-restricted eating is, for the most part, most people, when they say I'm doing intermittent fasting, they really mean they're skipping breakfast. Well, you hear it time and again from people like Walter Longo. You really need to not skip breakfast. You need to skip dinner if anything? Well, I understand. We live in a very social world. Socially, dinner is an event. It's a social event. So it's a unusual person that's actually doing time restricted eating and they're skipping dinner. But at least look at this. This survey was not even talking about skipping dinner. They were saying, look, at least don't eat that 8 p.m. snack. And I would agree. Don't eat that 8 p.m. snack. When you look at most people that I talk to that are doing time restricted eating, they're going from like 11 to or 1, 11, 12 or 1 till about 5 or 6. So they're taking those two middle blue bars and that's when they're eating. And you know what? That's not bad. You can do a lot worse, as you see from that second bar. If you look at me personally, there have been times, especially when our kids were very young. So I was eating at home a lot. I was not traveling as much. And, the kind of food that the kids were eating was, stuff that as an adult, I was not that hungry for. So for several years' time, I was able to skip dinner and eat breakfast. I've always been able to, though, skip that 8 p.m. snack. At least just do that. And if you're thinking about skipping food, but you can't or don't want to for social reasons, think about just having a salad, having stuff, with minimal dressing and or a little bit of olive oil and vinegar. Vinegar is a great component for salad dressing. So cut out the meat, the cheese, the dressing. Just make it like rabbit food. That takes discipline, though, doesn't it? So now we're going to talk about the long form discussion today: men's health, erectile dysfunction, cardiovascular prevention. Soon as Gilbert gives us the water ball. So let's talk about men's health. First of all, what is it? Like we said, you tend to think of, well, it's prostatitis, it's prostatic hypertrophy, it's prostate cancer, erectile dysfunction, the blue pill. Or a more technical term and more common term and actually more accurate term is LUTS, lower urinary tract symptoms. But the reality is, if you look at it a little bit more globally, it's a lot of other stuff. For example, cardiovascular disease, you can argue, you can debate whether or not that's a men's health issue, but men get cardiovascular disease clearly far earlier than women. Insulin resistance, same thing. Men start suffering from insulin resistance, and that's probably why they get cardiovascular disease earlier, because they're getting insulin resistance earlier. One of the major drivers is that men tend to carry more fat. And we know that has a huge impact on diabetes, prediabetes, insulin resistance. If you look at some of the chronic diseases, 1 in 3 men has high blood pressure. 3 out of 4 men are overweight. Hence, men start getting into insulin resistance quicker. Men are 2 times more likely to overdrink and binge drink than women. 17 out of 100 men smoke versus 13 out of 100 women. Men die an average of 6 years earlier than women. Almost twice as many men die of cardiovascular disease. 9 out of the 10 top causes of disease and death occur in men more than women. And as we've said multiple times, if you don't think that men tend to neglect their health, just um, ask somebody's wife. So I'm going to go to the example that brought all this up. It was a case of an ER doc. I have a lot of docs as patients. As I mentioned, more dentists than anything else, but I have a lot of physicians. I get a lot of arthritis doctors, rheumatologists, because they tend to understand the science behind inflammation better than other specialties. Um, but one of the most common specialties I have among doctor patients is ER docs, and I don't know why. I don't know why, but anyhow, it was one of my ER doc patients a couple of months ago was complaining about ED, and I started talking with him, and it was interesting. He really had no clue about the combination of symptoms that he was having. And it was, yes, some ED, but was having chronic prostatitis and didn't even know that the PDE5 inhibitors, it's like Cialis or Viagra, usually have a big impact on this. And he came back later and he said, "Hey, doc, well, it helped a little bit in terms of ED, but I'll tell you, uh, this stuff won me over immediately because I quit having pain." And it's like, he's an ER doc, or he used to be an ER doc. Well, again, like I said, the cobbler's children sometimes have no shoes. Um, so here's one of the articles we would quote, and we wanted to quote on this discussion. Current bladder dysfunction reports, 2013. The group was in Italy, in the U.S. PDE5 inhibitors, in other words, Cialis, Viagra, for the treatment of concomitant erectile dysfunction in LUTs, lower urinary tract symptoms, benign prostatic hypertrophy. And again, this stuff has become very common. When these things first came out 15 to 20 years ago, it was like, oh my gosh, it fell into this thing about sex. We don't talk about sex, any of us, very much, at least, with serious, productive discussions. And because we don't, we tend to be surrounded by way too much ignorance in this space, even among people who really should know. This article, by the way, explored the current evidence of prevalence on ED, LUTs, benign prostatic hypertrophy, and the underlying factors involved, and why scientifically the PDE5 inhibitors made a difference. So a couple of comments about prevalence. This is from Johns Hopkins Journal. The American Journal of Medicine, Johns Hopkins research team, 2007. Approximately 18%, that's 1 out of 5 men, are estimated to have erectile dysfunction. There's a high prevalence of erectile dysfunction in men with hypertension, high blood pressure, and diabetes. Guess what? If you have cardiovascular disease, erectile function is a cardiovascular function. That's why we're talking about men's health. Our channel is prevention, but we're doing a lot of primary care, and especially in the cardiovascular area. Current bladder dysfunction reports, 2013, Italy and the US. You looked at things like metabolic syndrome. So it gets into the details of the science. I tend to get very geeky in terms of the biology and the medicine and the metabolism. And that's what this article did. Most people that have any awareness of the mechanism are at least somewhat aware. The mechanism of the PDE5 inhibitors are somewhat aware of the impact on nitric oxide. So nitric oxide and the vasodilation, the dilation of the vasculature to um, allow an erection. But they also don't think about some of these other things, which end up impacting the prostate. There's a big influence of metabolic syndrome on the development of ED, BPH, and LUTS. PDE5s have had the ability, these drugs have had the ability to address multiple mechanisms that lead to the development of these diseases. In the Journal of Sexual Medicine, 2023, this year, US research group, there was they looked at these things again: Cialis, Viagra, the other PDE5 inhibitors, and cardiovascular events and death. So once you start seeing this, people start looking at, okay, what else does it impact? Does it actually prevent cardiovascular disease? There's still a significant debate in the literature over whether or not these prevent dementia. Actually, I had a patient just yesterday where this topic came up, and he'd read it and he was asking me, do I think they prevent dementia? The answer is, the short answer is, I don't think so. The jury is still out. There's been several articles coming out saying that these things prevent dementia, and there were like big numbers and big responses. So given what people saw in some of those early studies, you saw a boatload of other studies trying to repeat it. The studies developed to repeat that just fizzled, did not show a whole lot. Here's one of the studies that talked not about dementia, but about cardiovascular disease. This was a retrospective cohort study in the Journal of Sexual Medicine this year. It included more than 60,000 patients, compared patients using Viagra, Cialis versus controls. And the PDE5 inhibitor users had 13% less risk of cardiovascular events and death, and overall less mortality. So you see that kind of number coming out and you say, dang, are these saving lives? Remember, these are retrospective cohort studies. So things like participation bias can be a big deal. And I think that's a major part of what you're going to see in these studies. It reminds me of an old saying that Doug Thompson, the dentist that appeared many times on our channel, used to say, a healthy person has many problems and challenges. A really sick person only has one. Now, where did that come from, and what am I talking about? If somebody has some cardiovascular disease, erectile dysfunction, and they're healthy enough to be focused on sex, that in and of itself is a major marker for a relative component of health and age. So you got to tease all that out before you start saying, oh, guys that are taking these medications are healthier, therefore their lives are being saved. Well, maybe they came into the study more healthy. So other treatments for LUTS, lower urinary tract symptoms, and BPH, benign prostatic hypertrophy. Just run through a couple of these quickly. Again, usually men over 45. Newer medications include alpha blockers, anticholinergics, beta-3 adrenoceptor agonists. A lot of technical terms, and we are not urologists. We're not going to get that deep into some of those. But PDE5 inhibitors, Cialis, which is tadalafil and sildenafil and sildenafil, the blue pill Viagra, your primary care doctor should be familiar with these. And again, it's just like It's like just like primary care. This is primary care for urology. That's like primary care for mental health. There are not enough psychiatrists out there to deal with all the anxiety and depression that's out there. So a good primary care doc needs to know how to manage the majority, just one or two types of mental health issues with depression and anxiety. But those one or two types make up the majority of the problem. That is what a good primary care doc will do. Same thing here. A large portion of men's health in terms of LUTs, BPH, and ED is really just a PDE5 inhibitor issue. And again, your primary care doc should be able to provide care in that space. So as we're getting deeper into, men's plumbing, there's some other issues to talk about. I mean, the real core of men's health. And again, there's several things in that space, and it starts to get into urology and when to consult a urologist. Cystitis, prostatitis, prostatic abscesses, overactive bladder, bladder carcinoma, foreign bodies or stones, sexually transmitted diseases, neurogenic bladder, pelvic floor dysfunction. 233,000 men this year will be given a prostatic cancer diagnosis. The top 3 cancers for men in Utah are prostate, skin, and colorectal. Now, the good news is 95% of cancers, prostate cancers, can be managed. And if we as men will get a little bit more out of denial and postponement mode and more into let's take care of it, we've got much better opportunities to be where we need to be healthy and enjoying our life. If you're seeing a primary care doc, by the way, for some of these issues, consider a urologist if your primary care doc, even if he or she is not mentioning it. If you've got kidney disease, urinary retention, recurrent urinary tract infections, recurrent bladder stones, bloody urine, lower urinary tract symptoms that are just not responding to basic PDE5 inhibitor treatment. So there we go, an intro to a upcoming series on men's health. Gilbert, if you'll give us the transition, we will go into the Q&A. So there we go. As I mentioned, oh gosh, got a lot of questions today. As I mentioned, they started off with questions about supplements. Dwight Baldwin, Dr. Brewer, follow up from last week. Not a poor methylator, taking 500 milligrams niacin. What's an estimate of how much trimethylglycine I should take in this situation? And just to remind you, TMG is a carbon with 3 methyl groups on it. And it's mostly recommended for people that are poor methylators. Dwight's bringing up a good point, though, that if you're taking niacin, you're still stressing that methylation process. Niacin is a B vitamin, B3, and the whole idea behind niacin is to push some of that methylation, some of the energy currency program within the mitochondria. And it does stress methylation. So couple of points. Number one, we haven't covered it. It's a good question. What I have covered is that I'll usually put just a teaspoon of trimethylglycine in my zero carb smoothie, but we can give you a little bit more information than that. If you look at some of the standards, some have tried up to 6 grams per day. It's sort of like vitamin C, where people go to multiple grams. But the reality is the standard is much less. Start with half a milligram to a milligram, and that's where I usually tend to go. Now, is it dangerous at 6? Well, no, it doesn't appear to be. It's supposed to be safe as high as 15 milligrams in humans. But as you see from the emphasis, supposed to be is the maybe the operative word there. I do not recommend getting up to 15 milligrams. Okay. Let's see what we have next. Dinos Stogius. Is niacin recommended if someone had a stent after a heart attack? Should beta blockers be taken for life? As I have read that it's safe to stop 1 to 2 years after the event. I'm on 1.25 milligrams of bisoprolol. So here's the thing. You bring up a couple of key points, Dinos. And this all has to do with use of beta blockers. Beta blockers do make sense after events, and they make sense when people have heart failure. Now, there's a significant downside to them. They can make you tired. They can make it difficult for you to get your heart rate up, and they can increase your insulin resistance. So several components here. The first one is, when should you use it? As I think we mentioned somewhere. So let me just deal verbally with this, with the severity of the event. So if you just had a stent, you didn't have a heart attack that drove the stent. The evidence in the literature is much clearer that 6 to 18 months is much more of an appropriate time. You can and start asking your cardiologist about coming off of those afterwards. If you've had a heart attack, a myocardial infarction that led to the need for the stent, those, by the way, are the stents that actually save lives. The stents that are put there when you don't have an event don't seem to help. The ones that are saving lives, or again, any kind of heart attack, those tend to be longer. They tend to benefit longer, or from a longer duration of use of beta blockers. Now, the next question is, what kind of beta blockers? There are non-diabetogenic. How's that for a word? Diabetes causing, genic means causing. So beta blockers that cause diabetes. What are the ones that don't? Oh gosh, we got, so here are the ones that don't. Carvedilol or Coreg, Bistolic, Nebivolol, or Bisoprolol, which you mentioned that you're on. So Cardicor and a couple of others named that way. So I hope that's very helpful. That was a great question. And again, I hope that helps. Millard Woods. Last time we talked of AWV. I don't see any value to my Advantage Plan's free AWV. Could I use it for a doc exam? No. And a lot of doctors don't see value to your AWV either. And quite often, there's a major correlation. If your doctor doesn't see value to the AWV, they're probably not doing it right. And it's probably not taking you where you need to be. Now, a lot of us, there is some, the old commercial about Listerine, the taste you hate once a day. And there is some component to this too. You get into some things about depression screening, cognitive decline screening, end of life screening, things that activities of daily life screening, and some things that your typical healthy, very cognitively aware person that's watching this channel is going to say that's a waste of time. Well, again, come back and look at it from a Medicare perspective. When you're paying for the health care for the majority of 65 and older people in the US, these things slip up and cause major problems. These things are embarrassing, they're frustrating, they can be subtle, and they are devastating. If they're devastating to your health, they're going to be devastating to Medicare's budget. So that's why Medicare pays for those. So, I wish I could. I don't really wish that I could tell you that you could do that, because I think Medicare's right on that, and I hate to tell you. I'm sure I'm going to get a lot of haters to ever say that any federal government component is doing the right thing on something. But sometimes prevention can be dull and frustrating. One thing that your doctor's team can and should do, if they are able, if they're able to understand what's going on and why, they should be able to make the AWV relatively pain-free for you. And they should be able to also get you into some discussions, have discussions with you during the AWV that actually really makes sense for you at your level of health. So I think you should push back a little bit more with your doctor's team than with Medicare on that one, Millard. Okay. Bart Robinson, good morning, gang, from New Jersey. Rick Folia, can you do a YouTube short on where to find and how to interpret the AACE guidelines that say A1C is not how to diagnose diabetes? The 2022 guideline seems to be dependent on A1C. So, again, when Jesus and I were discussing things before we started the video today, and we're giving him a hard time about his surgical pajamas, he brought up this question, and he was saying, it's frustrating for us as content developers to put out something, and we put out this specific video, yet another version of it, just a few weeks ago, according to Jesus. So I think he's going to be going back, Rick. If not, I'll tell you what, Gilbert, if you will put up the email address, Rick, you can email us at myhealth@prevmedhealth.com, or call us at 859-721-1414. That's prevmedhealth.com. Visit us there. Send us an email. You can contact us through that site, or call us. And again, we can get that information for you. We have covered it many, many times. And let me just take the opportunity to explain that to people that have not seen it. Most doctors, the vast majority of doctors will say, oh, well, we screen for diabetes, and they're looking at A1C, and even they say they're looking at A1C. And even if you look at the actual data on what they're really doing, more often it's a fasting glucose that happened to come up for some other reason. They're not looking for it. Anyway, fasting glucose is a one shot. It's a single shot. It's like a picture of me standing in front of a bus. The whole story changes when it becomes a moving picture, a movie, and you find out the bus is actually running over me. Same thing, exact same thing. There's hidden dangers that we're just totally missing when we do a single snapshot. So why don't you do A1C? Everybody says, and most doctors say they use that. They don't even use that. A1C is supposed to have much more of a component of what the blood cells that we're measuring there. We're measuring the bonding of glucose, AGE, advanced easy for me to say, AGE, advanced glycolytic endpoints. Or it's not glycolytic. I'm missing the last half of that word. Anyhow, glucose binding covalently to protein. The most common AGE end product is hemoglobin A1C. Hemoglobin's a protein. It holds iron so you can hold oxygen, so you can metabolize much more effectively than a fungus. Well, so that actually gets to the point on why the AACE, the American Association of Clinical Endocrinologists, and the boards associated with endocrinology say you can't just use A1C alone because it involves the protein called hemoglobin, and that protein is impacted by a lot of things. Have you ever heard of beta thalassemia? If you have, it's a genetic variation of hemoglobin. If you haven't heard of that, you may have heard of sickle cell anemia, another genetic variation of hemoglobin. These things change A1C. Well, you say, oh, that's just an unusual genetic thing. Well, have you ever heard of pregnancy? Most of half of us have had that, and that impacts hemoglobin as well. Well, okay, so I'm a man. I don't have any of those genetic things. A1C should work for me. Well, not if you've had liver disease, kidney disease. So as you begin to see, that's why the AAC, the Clinical Endocrinology Board's standards committees say you need something more than just A1C. And again, if you can check in with our group, they can help you find that again. We've made that explanation a few times, and we've put that out there, and we do have it. According to Jesus, we put it out there again just recently. And good morning from Atlanta, Rick. Thank you it's a great question. Thank you for giving me the chance and the reminder to explain that. Good morning from Georgia. Good morning to you, Millard. Any doctors practicing the Brewer protocol in Atlanta? That's the other thing that we mentioned early on. And no, I'm going to ask you to refer your doctors there and see if one of them actually stops, focuses, gets off that treadmill long enough to start taking care of people. We're there to help. Margaret D., good morning from Winnipeg, Canada. E.T. himself, morning for BC, Canada, as in British Columbia. And good morning to Dr. Jesus. We've got a tired looking for name giving us a super chat, $10 contribution. Thank you so much. If you're interested in doing that, again, it does help. Every little bit helps. And that's how to do it right there. The vast majority of the income that I've made as a doctor seeing patients for this channel has gone back into paying salaries for folks like Gilbert, who helps with the technical, he's our co-host, does a great job in that space. Very, very good job. And he also does a great job with our graphics. So these kind of things, these little super chats may not mean much to you, but they mean a lot to getting this information out to the rest of the world. Ora Ruth, Kamiemi. Shalom, docs. Good topic today. Thank you so much, Ora Ruth. Ora Ruth is a healthcare professional. E.T. himself, Okanagan Valley, British Columbia, to be specific. Well, good to hear from you, and thank you so much for sharing the location. I hope I'm pronouncing that right, and I don't think I know that. My brother lives in Canada. So moving from South Carolina to Canada, that was a big deal for him. A little bit of a challenge. Darren Yeomans, thoughts on Cialis for vessel dilation therapy on your heart. I read about it, a story about it, reversing heart disease in sheep. So Darren, I'm guessing you wrote this before we covered that. That's one of those debates. Does Cialis, do the other CEDE5 inhibitors, are they, is there a place for them in cardiovascular health? Is there a place for them in dementia prevention? I'm not incredibly optimistic that these are going to turn out to be what we hope. In fact, I doubt it very seriously. But that debate's still going on in the science. And we covered one of those specific to cardiovascular disease today. The one we covered today looked like it was really some significant evidence that it would help. But I'm from Missouri on that one. For those of you who don't know what that means, people from Missouri in the United States are known for being skeptical. So when you say, I'm from Missouri, you're saying, I'm skeptical. And I'm skeptical that the PDE5s are going to end up saving lives from cardiovascular health or dementia. But you never know. I've been wrong before, and I'm sure I'll be wrong again. Thumbs up, folks. Thank you so much. Yes, if Gilbert, if you can show them how to do a thumbs up. The thumbs up, even if you don't want to make a contribution, a thumbs up is a great way to tell the AI, the artificial intelligence, the algorithm, this is worthwhile information. It costs you nothing. Another thing that does that is to pull eyeballs from another social media like Twitter and things like that. So if you put a link to our content and you put it on one of those other social media groups, and you pull a pair of eyeballs away from another social media platform to our home ones like YouTube, Rumble, Facebook, then they read that and they say, that's very important, very healthy. D. Dutton, please clarify TMG dose as 0.5 to 1 milligram is nothing. Well, as I said, please give us a little bit more time. We'll go back. We'll review the literature again and talk a little bit more about it. John Tucho, Medicare does not cover weight loss products such as Wegovy, but does cover the same medication if you have diabetes. Will Medicare ever cover these types of meds for patients that are borderline? I think you're saying that are borderline. And I think you see this kind of transition all the time. When new medications come in, Big Pharma is making boatloads of money off of these new medications. And insurers, no matter whether it's a private insurer or Medicare, they're going to be very restrictive about providing those medications. I remember I was doing a lot of AIDS research at the time that HIV became a big issue. And again, you just could not get AIDS-related medications. Now it's available on public health, in the public health environment. The PDE5s, the Viagra, when that first came out, it was the little blue pill. There were ads all over the place. It was only people that were paying out of pocket for it because insurance companies were not covering it. Now it's very well covered. Once something gets off of, loses its patent and you get a lot of competitors out there, the prices drop and it becomes much more available. That happened with Crestor. Gosh, just 5 to 10 years ago, Crestor was hard to get because it still had its patent intact. It was a better statin for that, for many reasons than the others that were being used, but it was expensive. You have the same thing right now with pitavastatin, Livalo. It's better because it's better than any of them because it's got that advantage of not causing, there are fewer side effects and most specifically, less side effect associated with driving diabetes and prediabetes, but it's still under patent. The maker is still making a ton of money. And because of that, it's harder to get pitavastatin. You see it now with the, things like Eliquis, Rivaroxaban, Xarelto. They're called NOACs, new oral anticoagulants or novel oral anticoagulants. Those things are a big issue, especially for those of us who have atrial fib, because atrial fibrillation multiplies your risk of stroke by 5 to 8 times. Taking a baby aspirin, which is what most people take for a quote easy blood thinner for cardiovascular disease prevention, baby aspirin doesn't work for atrial fib, and it has to do with how clots actually form in atrial fib. again, until those medicines lose their patent, it's going to be a lot harder to find them. And insurers, even public health insurers like Medicare, are going to make it difficult to cover them. Back to the medication that you talked about, Ozempic has been a big deal. It's been fairly recent that Medicare started covering Ozempic, but I have not had problems with Ozempic coverage for my Medicare patients. I've had problems getting access to Ozempic, different issue. Bobby Ocampo, another healthcare provider in the Philippines. Mabuhay, good life, beautiful life. Ricky the Gun One, good morning from North Carolina. Is there a defined average glucose that precedes or indicates that you are in ketosis? Or can it only be determined by measuring ketones? Yeah. Here's the problem with that concept, Ricky. As we start getting pre-diabetic, insulin resistance, diabetes, there's a thermostat. There's a nucleus in our brain that acts similar to a thermostat. It measures blood glucose, blood sugar, and it slowly gets used to running hotter and hotter with higher levels of glucose. It takes months. No, typically what will happen with my patients that come on board is we'll get that insulin resistance. We'll look at all of our metabolism, find that there's significant insulin resistance or even full-blown diabetes going on, and that they are now running hot. Their typical fasting glucose, for example, is 110. And their brain's okay with that because it's used to it. So as they start dropping their carbs, decreasing their body fat, they start spending more and more time at lower blood sugars. When I first did this, I started feeling hypoglycemic in the 60s. After a few months of running those lower temperatures, lower blood sugars, I'd get down into the 50s and it wasn't an issue. So that's what happens. Now, why am I going down that bunny hole as a result of your question? Is there an average defined glucose? So here's the thing. For some people, we start getting into problems. So we start getting hypoglycemic at glucose levels that they're not symptomatic. They're not an issue for other patients. And you could assume that, well, here, let me go and approach this a different way. Anytime you're burning fat, you're burning ketones. You create ketones. Ketones are just where you're taking, a fat is a triglyceride. It's a glycerol connecting three fatty acids. That's what a triglyceride is molecularly. If you're burning that, then you're going to have things like fatty acids and glycerol, both of which form ketones. Glycerol, for example, forms one of the most common ones, beta-hydroxybutyric acid. So the reality is not so much are you making ketones, it's how many are you making. So many of us, there is little to no correlation of symptoms. And the reality is, in terms of burning, a lot of this also depends on your diet. So if you're eating a ton of fat, you can be burning fat at much higher glucose levels than someone who's, as you say, I hope you're beginning to see, there's significant differences between levels that you get symptoms from hypoglycemia, between levels of when you're actually burning ketones, and those things may not correlate as well as you would like, Ricky. Good question. I stumbled a little bit with it, but I hope I hope I was able to get some worthwhile information across. Per Johnson, is Doppler ultrasound of the penis most important in ED diagnosis? I don't think so. That's getting beyond my primary care focus in this space, but no. I mean, I'm fairly comfortable that the answer is no on that. Josh Walker, anything similar available with concierge or people without insurance? Well, uh, Josh, I'm a little bit confused. And it's probably because I'm coming from my world, you're coming from yours, and we're maybe not too familiar with each other's. My world for the past 5 years has been, I mean, this program is prevention program for people without insurance or concierge kind of. It's technically direct pay. Concierge is something where we make all your appointments for you and things like your doctor's group makes all your appointments and it's a white glove treatment. We don't do so much of that. We're more of a self-serve, but it is direct pay and not insurance pay. We still have access for you in that space. And again, Gilbert, if you'll just show the email and the telephone number again, Josh, that's how you get. Just call that number and you can get set up with the what you're calling concierge, the direct pay or non-insurance program. Millard, problem with straight Medicare is cost of Part D if you have expensive drugs. That is a problem. It's a big problem. And I saw something about that recent. Oh, you know what? The feds, our legislative branch, is making some, trying to make some impact on that as we speak. If you're as much of a skeptic of our legislative branch as I am, I tend to very much believe in Mark Twain's quote about those that enjoy sausage or law should not watch either one of them being made. I think that's really an issue for the federal government. But the bottom line is they are working on this issue, and they think they made some progress just this year. Bobby Ocampo, a doctor presented in YouTube the effect of osteocalcin on muscle mass. He is recommending injection of osteocalcin to prevent loss of muscle mass. Any opinion? I am very skeptical of that. I will tell you, osteocalcin, it is the enzyme that is associated with vitamin K2 that's associated with diabetes and prediabetes prevention or cause. So my first thing is, why do an injection of that when there are much more natural means and less invasive means necessary? And I haven't seen the specific science behind that. I'd be very interested to see that actual evidence. D. Dutton, please comment on the retrospective literature that indicates the PDE5 ED drugs seem to reduce Alzheimer's odds ratio by 0.5. Well, D, I did. And I'll say it again. There's the debate on whether the PDE5 inhibitors prevent cardiovascular disease. We've talked about that a couple of times. We covered that in the long form content, and then we had a question about it. I mentioned that in the long form content when we were talking about cardiovascular disease. There's also a big debate in the literature right now where some researchers have seen what appeared to be significant declines in, or a significant decrease in, I always have word finding problems when I'm getting ready to say dementia. I think it's my own internal fear of developing dementia myself. So let me go back and mention again what I think you need to be very skeptical of. There are no clinical trials that I'm aware of yet regarding PDE5 inhibitors, things like Cialis and Viagra, and their hoped for ability to prevent dementia. This thing that you're bringing up, D. Dutton, the retrospective literature that indicates PD5 ED drugs seem to reduce Alzheimer's odds ratio by 0.5. In other words, cut the risk in half. Think about it. This is retrospective literature, and think about the problem with retrospective literature. I mentioned it before. It's a thing called participation bias. And let me just ask you this. Do you think the people that are going into dementia are going to be having as much sex as the people that are not? Let me repeat the question. In terms of study design, do you think the people that are starting to stumble into dementia, do you think they're going to be having as much sex, needing these medications, asking for them, using them, as much as people that are not going into dementia? Once you answer that question, I hope that becomes very clear why retrospective data on this issue, it's not going to cut it. It's very, very suspect. Bobby Ocampo, if liver is using fats in the liver for gluconeogenesis, is metformin preventive removal of fat in the liver? Theoretically, potentially, yes. So here's the thing. From a research perspective, I'm not aware of any evidence that would indicate that that's an issue on the long term. And here's the issue, Bobby Ocampo. I think we're maybe majoring on the minors when we get into that theoretical concern. What is the big problem with diabetes, prediabetes? Well, it's hormonal. And because of hormonal issues, we keep eating more and more carbs, and we keep piling on more and more carbs. We keep pushing more and more carbs into the liver. It's not that we've slowed down the liver's ability to burn that fat, turn it into glycogen and/or, burn that fat. It's more of an issue that we keep pushing more in there through fructose, carbs, etc. Once you start, and again, that's the whole thing. We're talking less about treatment, more about prevention. You start getting into prevention, and it is treatment. You slow down your carbs. You do all the things that you need to do for diabetes and prediabetes, and you're going to cure your, quote, fatty liver problem, end quote. So worry less about short-term impact metformin should have and focus more on lifestyle. Andrew McDonald, I'm confused with niacin. You had a small clip that I didn't really understand. Can it cause cancer? Thanks, Doc. I think concerns around niacin and cancer are just, I'm not concerned about niacin causing cancer. I'm concerned about niacin causing liver disease, liver inflammation and liver disease. In short term, niacin also pushes, just like statins, can push people down that insulin resistance highway, prediabetes highway. Unlike statins, when niacin does that increase in diabetes, it's more of a short-term thing. With statins, it's more permanent. As long as you're taking the statin. After you've been taking the niacin 3 to 9 months, it starts to slow down that glucose impact. But again, cancer, I'm not sure which slide you might be talking about, but I'm not worried about cancer so much with niacin. Shaquille Oatmeal. I'm not a big oatmeal fan. In fact, I don't have that debate anymore. As you know, one of the biggest things I do from a public health perspective is I'm one of those docs that's helping people discover undiagnosed diabetes and prediabetes. If I've had this discussion once, I've had it hundreds of times about people saying, well, Doc, you can't tell me that oatmeal is not good for me. It's right there on the box, the oatmeal box. It's good for your heart. Well, no, it's not. And I don't even have that discussion anymore. If somebody has, what they usually have in terms of prediabetes, diabetes causing this problem, I just tell them, look, I'm not going to debate oatmeal with you. I'm going to ask you to go ahead and get a Freestyle Libre. I'll write the script for you, and or just a blood sugar test, and go ahead and have your big oatmeal breakfast that you think is so heart healthy, and then measure your blood sugar. I usually don't have to have the debate after that. Okay. Shaquille says, I'm 51. I just had a calcium score scan done, and it was 1. Is that pretty good? Yeah, 1 is great. Is it good for a 50-year-old? Yeah, a 51-year-old? Yeah, it's still pretty good. Now you start to get into a debate. Is it 1 or is it 0? If it's 1, does that mean you have plaque? If you have plaque, you're now a cardiovascular patient. You're no longer primary prevention. And therefore, I would consider things like a low-dose statin and a baby aspirin. So if you'd like to get a little bit more information, we can help you with things like CIMTs and other ways of just finding out just how much do you have. We are getting late and the show's getting long in the tooth. As usual, we've got a lot of interest, a lot of people asking questions. We've had a couple of more folks. Let me just mention this real quick. We've had a couple of more folks, William Brewster and T-Bone, provide some super chat donations. Again, really appreciate that. I'm going to have to go. Thank you so much for your interest today. See you next week.